Hi guys, welcome for the KNO classes. This is your Nagaraj, your NORCET mentor and NORCET guide. I welcome you all for the very wonderful session that is your high yield topic MCQs. Okay, so we finished the all updates. Okay, we made you all update regarding the PPH and all your important national health programs. Okay, now we're going to deal with the all high yield topic MCQs. Okay, we'll be covering the all subject. Okay, we'll be covering the all subject. Okay, and we are bringing you the topmost. Okay, very important MCQ for the coming NORCET-10 and other various examinations. Okay, so this will be your civil selection series. Okay, means okay, if you're watching the all MCQs, okay, you may get the first question your NORCET-10. Okay, so you may have the like in front of desk. Okay, you may realize. Okay, so this one is attended by Nagaraj class. Okay, this one is attended by the Dhananjay class. Okay, so like that. Okay, so all exams. Okay, so exams. Okay, all exams. Okay, so you may expect the so many MCQs from our classes. Okay, so okay, so what's the our MCQ series? Okay, it will be very useful for you. Just you get understand. Okay, how will you solve the MCQs? Okay, how will you explain the rationalists? Okay, so our one MCQ is equal to four MCQs. Okay, means I'll be in detail. Okay, I'll be in detailedly explaining the all rationalists. Okay, all MCQs I'll be explaining why this one is right, why this one is wrong, like that. Okay, so one MCQ is equal to four MCQs only. Okay, so please be attentive. Okay, please be attentive. Please be focused. Okay, please be interested in the class. Okay, so don't be distracted by the all other distractions. Okay, nowadays so many things is going on. Okay, world war is going on, so many things is going on, so all the distractions keep aside. Okay, just focus. Okay, you have to put the blindings. Okay, side by. Okay, just focus on the NORCET-10. Just concentrate. Okay, sit and study for the NORCET-10 because next month you'll be having the NORCET examination. Okay, you should be ready, you should be fit. Okay, you should be well knowledge with the all your NORCET-10 examination. Okay, you should be ready for the NORCET-10 examination. Okay, I'll be making you. Okay, I'll be preparing you. I'll be making you to the fullest for the NORCET examination. Okay, so without delay. Okay, without delay, we'll start the session right now. Okay, so first question of the session. Okay, first question of the session. Okay, from the OG. So you can see here we're having the 20-year-old woman comes to the woman present. Okay, woman present with the complaints of wait. So women, okay, here we're having the 20-year-old woman present with the complaints of primary amenorrhea. Okay, here she's having the primary amenorrhea and her height is 159 centimeter and weighs around 48 kg. She has okay well developed breast and she doesn't have a pubic hair or axillary hairs. Okay, based on these clinical features, identify the primary diagnosis. Okay, we have to do a primary diagnosis. Okay, based on the given history. Okay, her weight is okay, her height is normally 159 centimeters. So we can say this one is a normal. Okay, this one is for normal for the South Asia people. Okay, so South Asia people it's normal. So weight is okay according to the normal her height. Okay, so 48 kgs are right. Okay, so appropriate for her weight. Okay, so you can see now she's having a what she's having a she's having a primary amenorrhea. Okay, she's having a primary amenorrhea means okay from the birth okay till the puberty she's not having any menstrual cycle. Okay, there is a complete absent of the menstrual cycle and she doesn't have a secondary sexual characters are absent. Okay, you can see like she's not having a secondary sexual characters. Okay, secondary sexual characters are incomplete. Okay, we can say partial or incomplete means she's having a brisk development. Okay, but there is no absent of pubic and axillary hairs. Okay, so that's what you are all your features were given. Okay, based on features. Okay, you just have to identify the diagnosis. Okay, option A is primary ovarian failure. Option number B is Sting-Leventhal syndrome. Option C is a Turner syndrome. Option D is a complete androgen insensitivity syndrome. Okay, that is what your complete androgen insensitivity syndrome. Okay, so yes. Okay, so choose your right answer. Okay, I want everyone. Okay, I want everyone to be attentive, focused, interested in the class. Okay, I want everyone should be commenting in the comment box. Okay, I'm waiting for your answer in the comment box. Okay, just try to put your answer in the comment box. Okay, because active participation. Okay, if you're involving in the session means okay, it will be very easy for you to understand. So it won't get bored for you. Okay, if you actually participating, okay, you're getting the comments and all means so you'll get so much interest to have a class. Okay, so that's why I'm requesting you to just try to put your answer in a comment box. Okay, I'll be waiting for your answer right now. Okay, so till that we'll see the all options right now. So in a there is a syndrome called as premature ovarian insufficiency. Okay, so that is what your failure or insufficiency. Okay, here what will happen, there'll be a premature. Okay, there'll be a premature stop of the functioning. Okay, stoppage of the functioning of the okay functioning of of your ovaries. Okay, your ovaries stop to function. Okay, within a less than 40 years. Okay, less than 40 year of age. Okay, less than 40 years usually the ovaries stop to function. Okay, that's what we call as like primary ovarian follicle, primary ovarian failure syndrome. Okay, so here what will happen? Here there will be a menstrual cycles will be present. Okay, menstrual cycle will be present. Okay, after ages. Okay, after ages. Okay, it will get stopped. Okay, it will get menstrual cycle will get stopped. Okay, that's main thing happens in the primary ovarian follicle insufficiency syndrome. Okay, so that's one is not a right answer. So we will see the second one, that is your Steen-Leventhal syndrome. Okay, Steen-Leventhal syndrome. Okay, it is a synonymous. Okay, Steen-Leventhal syndrome, nothing but a PCOD. Okay, PCOD or very popular disease. Okay, PCOS. Okay, polycystic ovarian disease. Okay, here what will happen? So we know that okay, there will be a premature ovarian cyst will be there. Okay, the ovaries will not get into the mature site. It will get into the cystic cells. Okay, means all water will flood in the ovaries. Okay, that's what we call as a polycystic ovarian disease. Okay, so many cysts cysts will be present in the ovaries. Okay, so if this one is ovaries, okay, so all cysts will be present in the ovaries like necklace pattern. Okay, that's what we call as a polycystic ovarian disorder. Okay, here what will happen? Here there will be a menstrual cycle. Okay, where there will be a menstrual cycle will be present. Okay, there will be menarche. Okay, pleasant will be there, but irregular menses. Okay, there will be a irregular menses will be there, or abnormal menses will be there. Means heavy bleeding. Okay, less bleeding like that will be there. Okay, irregular or abnormal menses will be there, but there will be a menstrual cycle will be present. Okay, there will not be any primary amenorrhea. Okay, here what will happen exactly? There will be a hormonal imbalance. Okay, there will be a hormonal imbalance will be there. So male hormones will be more. Okay, so androgens will be more. So that's why there will be a hirsutism will be there. Okay, this will so main problem will be a infertility. Okay, here in a PCOD there will be a infertility is the most common problem in the PCOS. Okay, so that's regarding the Stevens-Leventhal syndrome. Okay, next one to see Turner syndrome. Okay, Turner syndrome. Okay, Turner syndrome. What will happen in a Turner syndrome? So there will be a deletion. Okay, there will be a deletion in the chromosome. Okay, there will be a deletion in the X chromosome. Normally, what should have? We should have a 46 XX. We should have. Also, okay, if female child, okay, we'll have a 46 XX. In a male child, okay, there will be a 46 XY will be there. Okay, so based on the Y, okay, if Y is present, okay, we can say male. Okay, if Y is absent, we say female. Okay, so here in Turner syndrome, what will happen? One chromosome will be deficient. Okay, so 45X0 will be there. Okay, so that is a, we can say, X monosomy disorder. Okay, it is a X monosomy disorder, means one X chromosome will be absent. Okay, we know that. Okay, so X chromosome is very important. Okay, X chromosome is very important for female sexual character development. Okay, so we know that. Okay, so in Turner syndrome, okay, in Turner syndrome, what will happen in Turner syndrome? So there will be a deletion of the one X chromosome. So X0 will be there. So what will happen? So there will be incomplete, okay, incomplete development of incomplete development of female female sex organs. Okay, female sexual organs will be there, means organs will be there. Okay, your ovaries will be there. Okay, your breast tissue will be there. Okay, everything will be there, but everything will be incompletely developed. Okay, incompletely developed. Okay, so that's why. Okay, so ovaries requires both. Okay, ovaries requires both X chromosome to be present, then only ovary will start to have a functioning. Okay, so here because of absent of one X chromosome, what will be there? There will be a streak gonad. We can say there will be a streak ovaries will be there, means complete ovaries will not be developed. Okay, there will be a streak ovaries, or there will be a absent. Okay, absent ovaries will be there. Okay, that's why what will happen if the ovaries are absent? Okay, if streak ovaries are there, there will be a absent menstrual cycle. Okay, there will be absent menstrual cycle. We call that one as a primary amenorrhea. And you can see all your secondary sexual characters. Okay, all your secondary sexual characters are incompletely developed. Okay, they'll be incompletely developed. Okay, that's why there'll be incomplete sexual characters, secondary sexual characters will be there. Like it, so there'll be a breast buds will be there, but there'll not be any pubic hairs or axillary hairs will be there, like that. Okay, means incomplete development will be there. Okay, that's what you are regarding the Turner syndrome. Okay, and next one, that is your CZAC. Okay, CZAC nothing but a complete androgen insensitivity syndrome. Okay, actually here what will happen? Okay, this one is the XY disorder. Okay, male disorder. Okay, it is a male disorder. Okay, what will happen here? There will be a mutation of androgen receptor. Okay, here there is a mutation of mutation of androgen receptor. Okay, all our male hormone receptor will be mutated. Okay, they'll be insensitive to the like our male hormones. Okay, androgen nothing but so there'll be a androgen receptor insensitive mutation will be there. Okay, so that's why the all males. Okay, males will be having a all males will be having the all female characters. Okay, all female characters will be there. Okay, female characters will be there. Nothing but they'll be having the female. Okay, they'll be having the female genitalia. Okay, they'll be having the female genitalia will be present. Okay, but they'll not be having a any like testis will not be there. Okay, so actual male genitalia will not be there. Instead of actual male genitalia, there will be a female genitalia will be there. Okay, that's regarding the CSAC. Okay, CSAC. So just come for the questions right now. Okay, here what we're not will be having, I told you, okay, primary amenorrhea and secondary sexual characters are incomplete. So all features of Turner syndrome. Okay, so option number C is the right answer. Okay, but you can see in Turner syndrome, okay, there will be a short structure will be there. Okay, in most of the case, okay, there will be a short height will be very less. Okay, but here they given a normal height. Okay, to just confuse you. Okay, that's regarding the like first question. Option number C is the right answer. Okay, Turner syndrome is the right answer. Next, we'll go with the second question right now. So this one is the like image based question. Okay, I picked the image based question. You can see NORCET. Okay, NORCET and 8 and 9. Okay, they asked it regarding the X-ray and they said to diagnose the X-rays. Okay, so diagnosing the X-ray is very important part for us also. So nowadays we are not only limiting for the nursing diagnosis. Okay, we have to do a medical diagnosis also. So that's why I picked the very important question from the medicine. Next, what are your X-rays? Okay, just look into the X-rays. Okay, just look into the X-rays. Okay, here we're having the 25-year-old male present to the emergency department with the road traffic accident. Okay, and immediate X-ray was taken to immediate X-ray was taken. Based on the given X-ray, identify the abnormal findings. Okay, based on the like X-rays, we have to find the abnormal findings. Okay, option number A is lung abscess. Option number B is pneumonia. Option number C is pulmonary edema. Option number D is the pneumothorax. Okay, you can see the like options right now and just try to analyze the question. Okay, just see the like X-ray and interpret the X-rays. Okay, so after that only you'll get the which kind of like abnormality is that. Okay, you can see. So you can see. Okay, even like right side. Okay, right side of the lung. Okay, this one is the left side of the lung. Okay, so you can see here. Okay, here margins. Okay, lung margins. You can see lung margin. Okay, costopharyngeal angle is very sharp. We call that one as like Shillot sign. Okay, Shillot sign is there. So this one like greater vessels. Okay, this one is the your bronchi are there. Okay, and here you can see aorta, arch of aortas. So this one is a cardiac shadow. Okay, this one is a cardiac shadow, and you can see this one is a left lung. Okay, left lung. Okay, this is a normal X-ray. So you can see here. So here you can see all bronchovascular markings are present. Okay, but here you can see there is absent bronchovascular markings. Okay, so lungs has been pushed up. Okay, lungs has been pushed out, and you can see the tracheal deviation. Okay, here you can see blackout lung. Okay, so that's what your like trachea is being deviated to the right side. Okay, so your trachea has been pushed out. Okay, pushed out to the left side. Okay, because there is a tension pneumothorax. Okay, so you can see. So they given a history of RTA. Okay, RTA what will happen? There will be a blunt trauma chest. Okay, in RTA cases, what will happen? There will be a blunt trauma chest will happen. Means nothing but a blunt trauma to the chest. Okay, that will lead to the rib fracture. Okay, so ribs will be getting pierced into the pleura. So there will be in a pleura. Okay, normally pleural fluid will be there. Okay, pleural fluid will be replaced by the air. Okay, that's what we call as pneumothorax. Okay, in case of flap, okay, just one flap is there. Okay, just opening flap is there, or it opens on the inspiration and close on the expiration. So air will be keep on depositing into the pleural cavity. So that way it will push the lungs into the one side. Okay, so that all he can see all features are indicating of you can see. So there is a blackout lung. Okay, blackout nothing black nothing but the air. Okay, complete air. Okay, the air will be the air on X-ray. Okay, the air on X-ray will be seen as black. Okay, will be seen as the black. Okay, but if you see like any like other abnormal tissue or the bone. Okay, bone will be hyperdense. Okay, bone will be hyperdense will be there. Okay, so that's why full blackout lung is there. Okay, without any bronchovascular markings. Okay, so that denoting a complete picture of pneumothorax. Okay, pneumothorax. So we'll write down. Okay, what all features are there. So on X-ray. Okay, on X-ray of the pneumothorax. Okay, on X-ray of the pneumothorax, what are all different findings will be there. Okay, so what are the different findings will be there. Okay, on of pneumothorax. So first one I told you. Okay, there will be a complete absent. Okay, complete absent of the complete absent of the bronchovascular markings will be there. Okay, bronchovascular markings will be completely, they'll be absent. Okay, bronchovascular marking will be absent on the X-rays. Okay, so next one. Okay, next one to say there'll be a tracheal deviation will be there. Okay, there'll be a tracheal deviation will be there. There'll be a tracheal deviation, and if we see, okay, on the on percussion, okay, on percussion of the chest, okay, on percussion of the chest, you can have a hyper resonance. Okay, you can have a hyper resonance will be there. Okay, if you percuss on the chest, okay, there'll be hyper resonance because there'll be a air. Okay, there'll be a air. Okay, or else you can say there'll be a dull sound. Okay, so no, so there'll be a hyper resonance will be there on the percussion. Okay, you can see this all are the features. Okay, this all are the feature of the pneumothorax on the X. This all are the clinical features. Okay, this all the features can be seen in the X-ray. So you can see all other options. Okay, in lung abscess. Okay, in last class I taken X-ray of lung abscess. Okay, what will happen in X-ray? So there will be a white cavitation will be there. Okay, center there will be a hollow will be there. Okay, center there will be hollow. Okay, abscess. Okay, you can see abscess what will happen? There will be a pus center. Okay, pus center filled with the tissue. Okay, pus with the tissue will be there. Okay, so the tissue surrounded with the pus will be there. Okay, so that center there will be hollow and center there will be a cavitation will be there. Okay, cavitation will be there. That's what you can see in the lung abscess. Okay, in pneumonia, I can see pneumonia there will be consolidation. Okay, one side of the lobe. Okay, there will be a consolidation. Okay, so that will be seen as the white lungs. Okay, consolidation tissue will be there. Okay, in a pulmonary edema, there will be a white out lung will be there. Okay, we can say there will be a white out lung X-ray will be there. Okay, so nothing but really hyperdense area. So we can say wet lung. Okay, in pulmonary edema is also called as wet lung or a shock lung. Means the lungs will fill with the water. We know that water will be white seen on the X-rays. Okay, hyperdense. So it will be a white out lung will be there. Okay. So only pneumonia you'll have a blackout lung. Okay, you'll have a black lungs. Okay, black lungs will be there. Okay, black lungs will be there. Okay, hyper black lungs will be there. Okay, that's regarding the second question. All of you clear? All of you getting or not? So if you're getting, okay, just give a thumbs up. Okay, so that I'll get to know. So you all are getting the classes right now. Okay. If any doubts, okay, just try to put a comments. Okay, I'll just try to put a comment in the comment box. Okay, I'll be there for solving all your doubts. So next question. Okay, I'll move towards the third question of the session. Here we're having the 65-year-old female came to the oncology OPD. So who has recently undergone for the surgery for the papillary thyroid carcinoma. Okay, papillary C. Okay, papillary thyroid carcinoma. Post-operative findings are extranodal invasion and no lymph nodal metastasis. Okay, after the complete excision. Okay, so which of the scoring system is used for the assess the prognosis of the post-operative setting? Okay, means here the patient is already undergone for the surgery. He has finished with the complete resection, and okay, after that, okay, they want to see the prognosis. Okay, they want to see the post-operative prognosis. Okay, here they wanted to see the post-operative prognosis of thyroid cancer. Okay, post-operative prognosis of the thyroid cancer. Okay, thyroid cancer. So which scoring system is used for the assessing the post-operative thyroid carcinoma? So option number A is AGIS scoring. Option number A is AMS scoring. Option number C is TNM scoring. Option D is MACIC scoring. Okay, so you can see. So option number D is the right answer. Okay, MACIC scoring nothing but M for metastasis. Okay, M for metastasis. M for metastasis. A for age. A for age. C for complete resection. Okay, I'll write down here. Just see. Sorry. So option number C is the right answer. So option number D is the right answer. That is what we call as MACIC scoring. Okay, MACIC scoring. Okay, this one is specially okay. I think everybody knows regarding the TNM classification. So, but MACIC score, it should know okay differently. Okay, what I'm telling no. So, which one is like known by everyone? Okay, in the examination, okay, everyone will answer. Okay, easy question. Those known by everything. Okay, they will answer everyone. Okay, but if you know something, okay, 1 hour. Okay, especially I'm telling you, 2 or 3 questions will decide your selection. Okay, you are getting selected or not. Okay, means which is not done by everyone. Okay, which is not attempted by everyone. If you attend that question, so you will be getting selected. Okay, so that's decide your selection or not. Okay, that's what your actual preparation for the NORCET-10 means. Okay, some people are not getting selected. Okay, they'll be completely in a NORCET, like a previous NORCET and all, they will not get selected just because of 2 or 3 questions. Okay, that's 2 or 3 questions are this question only. Okay, this high topic. Okay, this like all different variety of the questions only decide your selection or not. Okay, so everyone will study the theories. Okay, syllabus. Okay, so syllabus will be same for everyone. But what are the updates? Okay, what are the new thing? Okay, what are the deeper things you should know? But you should know. Okay, so I think everyone knows regarding the TN1 classification, but nobody knows regarding the mass scoring. Okay, so I'm preparing you for the highest one. Okay, I'm preparing for the highest one, so that lowest one will be known by everyone. Okay, so mass scoring. Okay, especially this one you use it for the prognosis. Okay, to check the to test the prognosis of thyroid cancer. Okay, thyroid cancer. Okay, especially this one is used for the scoring. Used as post-operative tool. Okay, post-operative tool to predict the whether the case is like resolving or not. Okay, M for metastasis, M for metastasis, A for A for age, A for age, and C for complete resection, means tumor is completely resected or partially resected. Completeness of resection, completeness of resection, and C and I for invasion, I for invasion, and S for size of the tumor. Okay, S for size of the size of the tumor. Okay, this is the MASIC score. Okay, MASIC score use it for telling the prognosis after the surgery. Okay, you can see TNM classification nothing but a tumor. T for the tumor, N for the node, M for the metastasis. Okay, this one also use it for this one is the TNM classification use it for scoring and grading. Okay, grading the tumor. Okay, grading the any tumor. Okay, this one is specially used for pre-op case. Okay, not the post-op case. Okay, TNM classification used for a pre-operative patient. Okay, not for the post-operative patient. Okay, for post-operative patient we'll use the MASIC score. Okay, that's the right answer. Okay, option number D is the right answer. You can see external invasion, lymph node involvement, metastasis. Okay, this all are the component of your MASIC score. Okay, so option number C is the right answer right now here. Okay, next we'll go with the fourth question. Okay, next we'll go with the fourth question of the session. That's your. So you can see I'll read out the question right now. So here I'm having the 56-year-old. So here you can see here we're having the 56-year-old patient admitted in the endocrinology ward with the complaints of severe headache. Okay, with the complaint of severe headache, uncontrolled hypertension. After evaluation found that okay, patient is having a extra adrenal mass. Okay, extra adrenal mass is there, which among the most common site of extra adrenal mass, we can say extra adrenal mass nothing but a extra adrenal pheocytochroma, means most common site. Okay, most common site of extra adrenal. Okay, extra adrenal pheocytochroma. Okay, pheocytochroma. Okay, pheocytochroma. Here they are asking you regarding the most common site of extra-adrenal pheocytochroma. Okay, just try to put the answer in the comment box. Okay, I'll read the options right now. Okay, option number A is pancreas. Option number B is organ of Zuckerkundi. Option number C is a parotid gland. Option number D is the adrenal medulla. Okay, just try to analyze the question. Okay, just try to put the answer in comment box. Okay, I'm waiting for your answer right now here. So let's see the answer right now. Okay, you can see like pheocytochroma, nothing but it's an like adrenal medulla tumor. Okay, so what will happen here exactly? You can see. So this one is your this one is your kidney. Just consider this one is your kidneys. So like on top of the kidney we are having the adrenal gland. Okay, on the top of the kidney we are having the adrenal gland. Okay, so adrenal gland will divide into the two different part. Okay, especially will divide into the two different parts. That one is adrenal medulla and cortex. Okay, medulla is nothing but the center part. Okay, medulla nothing but the always center part. Okay, and cortex nothing but the peripheral part. Okay, this one is if your adrenal gland. So center part will be considered as medulla, okay, and peripheral will be a cortex, okay. Peripheral will be a cortex. So if you see pheocytochroma, so nothing but it is a pheocytochroma, okay, pheocytochroma, nothing but like color producing cancer, okay, cytoma. Okay, pheochromocytoma. Okay, pheocytochroma. Okay, okay, that's where like adrenal medulla tumor. Okay, pheocytochroma. Okay, pheocytochroma. Okay, so that's regarding your like here how it will happen. So we know that okay at the medulla, adrenal medulla, they will be producing of adrenaline hormones. Okay, your adrenaline and noradrenaline. Okay, and dopamine. Okay, and dopamine. All three your emergency hormone. Okay, your sympathetic nervous system hormone, adrenaline, noradrenaline, and dopamine. Okay, all produced from the adrenal medulla only. So here what will happen? This one is the hyper secreting tumor. Okay, this pheocytochroma will be a hyper secreting tumor. Means if the tumor cells is growing on, so there will be more production of your more secretion of your adrenaline, noradrenaline, and dopamine. So what will happen due to all this? Okay, there will be a increased sympathetic drive. Okay, there will be increased sympathetic drive will be there. Due to that one, there will be increased heart rate, increased blood pressure. Okay, there will be a headache will be there. Okay, there will be sweating, there will be tremors. Okay, all the features of sympathetic nervous system stimulation will be there. Okay, that's what your pheocytochroma. Okay. In this, okay, in this, normally I told you where it will happen in the center of the adrenal gland. Okay, but here what is happening? Okay, there is a extra adrenal. Okay, here the tumor is happening at the outside the adrenal gland. We call that one as extra adrenal pheochromocytoma. Okay, pheochromocytoma. Okay, so that's what your extra adrenal pheocytochroma. Okay, so most common site will be, you can see this one is the aorta. Okay, this one is your aorta, and this one is your common iliac artery. So here is your kidney. Okay, here is your kidneys. Okay, here is sorry, here is your kidneys consider. So just above the kidney, okay, there will be adrenal gland. But here, okay, what will happen? The organ of Corti, we call that one as organ of Corti. Just below the kidney, there will be a there will be a organ of Jukar Khandi. Okay, there will be organ of Jukar Khandi. Okay, this is the most common site. Okay, this is the most common site for extra-adrenal pheochromocytoma. Okay, this option number C is the right answer. Okay, you can see option number C, organ of Jukar Khandi. Okay, organ of Jukar Khandi is the most common site for extra-adrenal. Okay, extra-adrenal pheocytochroma. Okay, external pheocytochroma. Okay, that's the most common answer. Okay, so option number B is the right answer. Okay, all of you getting? Next one from the surgery part. Okay, just how to identify the given image. Okay, just you have to identify the given image. Okay, this one is your given image. Okay, just you identify the given image. Okay, options are here. Option number A is bone cutter. Option number B is the green armitage forceps. Option number C is Alice tissue forceps. Option number D is Babcock forceps. Okay, options are here. Just choose a right answer. Okay, so right answer is a direct one. Okay, this one is the bone cutter. Okay, this one is the bone cutter. You can see sharp angle is there. Okay, so with the stronger handle is there. Okay, that's for the bone cutter. Okay, use it for the amputation of the bones. Okay, just one see. That's all other options. Okay, you can see. So first image is okay. First image is of Babcock forceps. Okay, this first one is of Babcock forceps. Okay, this one is specially used for laparotomy. Okay, so during laparotomy, they wanted to hold. Okay, they wanted for Babcock forceps. Okay, this one is used to hold the delicate tissues. Okay, like your intestine. Okay, if you want to hold the intestine, okay, and arteries, and if you want to hold means okay, very delicate organs you want to hold means you can see. So very soft. Okay, very soft blended angle is there. Okay, with the hollow window. Okay, you can see hollow window is there. Okay, this one is especially used during the laparotomy to hold the intestine and other various delicate tissues. Okay, and you can see second one. Okay, second image is of green armitage. Okay, second image is of green armitage. Okay, green armitage force. So we can see serrations are present. Okay, serrations are present. Okay, with the liver locking feature. Okay, the liver locking features are there. Okay, this one is specially used to ligate. Okay, stop the bleeding. Okay, this one is especially used to stop the bleeding. Okay, hold the vessels. Okay, with the using this one, they will hold the vessel or the any dense tissue. Okay, if you want to hold the dense tissue, you can use the green armitage force. Look at the third one. Third image is of Alice tissue holding force. Okay, Alice a tissue holding forceps. Okay, third one is image of Alice tissue holding forceps. We can see serrations are there. Okay, here if you want to hold the fascia, we know this. Okay, fascia is very stronger. Okay, very stronger. We want to hold the fascia. We want to retract the fascia means that time we can use the Alice tissue holding forceps. Okay, that's regarding the like all your image based question from the OT. Okay. So next we'll go to next question. Okay, sixth question of the session. Here we're having the 65-year-old female present to the emergency department with the complaints of chest pain and the left hand numbness. Okay, and ECG was taken. Okay, ECG was ordered by the treating consultant. Okay, so you have to interpret the given ECG based on the clinical features. Okay, you can see the ECG right now here, and you can I can put the right answer in the comment box. Okay, so option A is anterior MI, option number B is inferior MI, option number C is unstable angina, option number D is the NSTMI. Okay, nothing but a non-ST elevation MI. Okay, options are right now. Just try to choose the right answer. Okay, I'm waiting for your answer right now. So just try to see the ECG carefully. Like you can see, analyze the leads. Okay, you can see or not like you can see in the V2 lead. Okay, there is a ST elevation. Okay, in a V2 lead and V3 lead. Okay, all your precordial leads. Okay, V2 and V4 also ST elevation is there. Okay, V5. So and V6 only like depression is there. Okay, ST depression is there. So like all your precordial list. Okay, you can see. So I told you. Okay, V1, V2. V3 and okay V4. Okay, so this all leads are having, okay, we call this one as precordial leads. Okay, precordial leads. Okay, the all precordial leads are having ST elevation. Okay, there is a ST elevation is there. Okay, you can see reciprocal leads. Okay, you can see the reciprocal leads. Okay, that is your lead number 2 and lead number 3. Okay, they are having the ST depression. Okay, there is a ST depression. Okay, you can see there is a ST depression in the lead number 2 and lead number 3. Okay, so reciprocal we call that. Okay, the lead number 2 and 3. Okay, lead number 2 and 3. Okay, we call that one as this two leads as reciprocal. Okay, reciprocal. Okay, reciprocal leads. Okay, we call this one as reciprocal leads. Okay, they are having the ST depression. Okay, this all two are okay. Precordial leads ST elevation and the reciprocal leads ST depression. Okay, this is all of the classical feature of anterior wall MI. Okay, this all are the classical feature of anterior wall MI. Okay, in inferior wall MI, what will happen? So there will be a ulta. Okay, in a precordial leads. Okay, there will be a ST depression. Okay, there will be a ST depression in the precordial leads and ST elevation. Okay, and the ST elevation in the reciprocal leads. Okay, this is the feature of inferior wall MI. Okay, inferior wall MI. Okay, these two are the like classical feature of your anterior wall MI and posterior wall MI. So and inferior wall MI. Okay, so we know that okay, anterior wall MI is very dangerous. Okay, there will be a LAD obstruction. Okay, our left anterior descending artery obstruction will be there in a anterior wall MI. Okay, so this will be very destructive. The patient will have a sudden bradycardia, sudden hypertension will be there. Okay, in the inferior wall MI there will be a RC. Okay, right coronary artery block will be there. Okay, it's very like less dangerous we can say compared to anterior wall MI. So in inferior wall MI is very less dangerous. Okay, so in LAD block, okay, in the anterior wall MI, so we call this anterior wall MI also as the STEMI. Okay, STEMI nothing but a ST elevation MI. Okay, it's very dangerous. Okay, we need to thrombolize the patient. Okay, we need to thrombolize the patient with the thrombolize the patient with teneclaptase or STK or a retifast. Okay, with the thrombolytic agent, we have to thrombolize immediately. We have to do a PCI. We call that one as a primary coronary intervention. Okay, we have to do a primary coronary intervention. Okay, means immediately patient has to be taken for the coronary artery CAG, and they have to do a stunting process and all. Okay, so it's very important to manage the anterior wall MIs. So option number A is the right answer. Okay, you can see unstable angina. There will not be any changes in the ECG because there will be only chest pain. Okay, the myocardium is still alive. There is no any death of the myocardial tissue. That's why unstable angina. There will not be any ECG changes will be there. Okay, in NSTMI, so non-ST elevation MI. Okay, non-ST elevation MI. There will be ST depression will be there. Okay, that's what your non-ST elevation MI. Okay, nothing but all there will be hyperacute TUS will be there. Okay, this all of the cardinal feature of non-ST elevation MI. All this will be a T wave inversion will be there. It's all of the clinical feature. Okay, so in NSTMI, what will happen? You can see. So in NSTMI, okay, nothing but a non-ST elevation MI. Okay, this is very less dangerous. Okay, it's very less dangerous than the STEMI. Okay, less dangerous than the STEMI. So what we'll do in that? Okay, in that we'll load the patient. Okay, we give a loading dose of MI. Okay, we'll give a loading dose of MI and we'll treat with the antiplatelets. Okay, we'll treat with the dual platelets. Okay, here we'll not go for the aggressive management. Okay, here what will happen? There'll be a hyperacute T wave, or else there'll be a T wave inversion, or there'll be a ST depression will be there. Okay, there'll be a ST depression. Okay, these three are the features of the NST MI. Okay, non-ST elevation MI. Okay, all of you clear regarding the anti-wall MI ECG changes? So if you clear means okay, we'll move towards the next question. Okay, so coming for the seventh question. Okay, coming for the seventh question of the session. Here we are having the, you can see here we're having the 67-year male admitted in a coronary care unit, okay, with the complaints of dyspnea, chest pain, and as a routine examination, okay, ECG was taken for observing the like ECG doctor ECG, okay, for by observing the ECG, the doctor diagnosed him as the old case, okay. So by seeing on the ECG, you can say, okay, the patient is already had a MI previously, so you can say old case of MI. So what is the pathognomic sign? Okay, what is the pathognomic sign of old MI on the ECG? Okay, old MI on the ECG. So you can see the options right now here. Option A is ST depression. Option B is Levine sign. Option number C is the T wave inversion. Option number D is the deep Q wave. Okay, so options are right now here. You can choose the right answer. Okay, what are the cardinal sign of old MI in the ECG? You can see. So you can see. Okay, so normal ECG will be normal, P wave will be there. Okay, the mild, okay, Q wave will be the negative wave. Again, QRS wave. Okay, QRS and T wave will be there. Okay, P, Q, R, S, T will be there. Okay, you can see the Q wave. Okay, the always, okay, Q wave will be smaller than the R wave. Okay, normally it should be. Okay, normally Q wave should be smaller than the R wave. Okay, so that is normal ECG. Okay, in case of old MI, what will happen? So your Q wave will be deeper. Okay, Q wave will be deeper, and you can see then this one is the T wave. Okay, this one is the Q wave. Okay, so here what will happen? The Q wave. Okay, Q wave will become larger than the R wave. Okay, this is a what we call as pathological. Okay, this is a deeper Q wave. Pathological. We call that one as pathological Q wave, or else a deeper Q wave. Okay, this is a cardinal sign of old MI. Okay, based on the seeing in the ECG, you can say the patient is having the old case MI or a new case of MI. You can see ST depression is also seen in case of new acute. Okay, acute MI. You can see the ST depression. Okay, Levine's anything but in case of MI, what will happen? The patient will hold his chest. Okay, you can say chest tightness. Okay, I'm having a severe pain in the intense pain is there in a left heart. Okay, left chest. You can say that's what we call as Levine sign. Okay, you can see T wave inversion is normally present in case of okay hypokalemia. In case of female, okay, female with the skeletal muscle injury can have a T wave inversion also. Okay, that is not a cardinal feature. Okay, you can see in MI also you can see the T wave inversion, but it's considered to be a non-specific one. Okay, it's considered to be a non-specific or a we can say non-significant. Okay. So option number D, deeper Q wave is the like a right answer. Okay, you can see here. Okay, you can see like a lead number 2, lead number 3, and augmented vector 4. Okay, you can see the pathological Q wave. Okay, Q wave is gone deeper than the R wave. Okay, that's what the pathological Q wave. Okay, this is the ECG of the pathological Q wave. Okay, pathological Q waves. Okay, Q waves, or we can say deeper Q wave. Okay, or we can say deeper Q wave. Okay, seen in case of old MI. Okay, old MI, you can see the pathological Q waves. Okay, all of you clear regarding the pathological Q waves? So, if you clear means okay, we'll go with the next question right now here. So, eighth question. Okay, here we're having the pregnant woman. Okay, with a known case of diabetes came to the OPD for a routine checkup. Okay, at the 36 weeks of gestation. Okay, and she has advised for the NST. NST is nothing but the non non-stress test. Okay, non-stress test is the NST. Okay, so NST was taken based on the like NST findings. Okay, identify the abnormal findings. Okay, here they given a image. Okay, this is not an ECG. Okay, it's the image of the NST. Okay, based on image of the NST, you can identify the primary diagnosis of the abnormal findings. Okay, you can see. Okay, here we are having the we are having here right in front of you the NST. Okay, just see the like NST and identify and interpret the abnormal finding of the NST. Okay, so after identifying the abnormality, you can choose the right answer right now here. Option A is the absent variability. Option B is a reactive NST. Option C is a beat to beat variability. Option C is a sinusoidal pattern of the NST. So choose the right answer. Okay, I'm waiting for your answer right now here. Okay, before that one, we'll see, okay, NST, regarding NST, because it's very important to know regarding the NST and the CTG. Okay, NST and the CTG. Okay, the basic difference is like if you're doing the NST in the like before the labor start. Okay, that's what we call as NST. If you after the labor has been started, okay, after the contraction is started, that time if you do the NST, we call that one as CTG. Okay, CTG. That is a basic difference between the NST and CTG. So here what we'll do exactly, okay, we'll attach the transducer, okay, at the before the labor start, okay, they will attach the transducer, okay, where they'll attach, okay, they will attach the transducer on the abdomen of the mother, okay, transducer is attached, okay. So for attaching transducer, you have to find out the back of the baby, okay, back of the baby, because back of the baby only the heart will be there, okay, back of the baby, okay, back of the fetus, we can say, okay, how we can identify the back of the baby by doing the leopard maneuver. Okay, we can go for the second stage of leopard maneuver. Okay, second leopard maneuver. So we'll do a leopard maneuver and we'll identify the back. Then we'll attach the transducer. Okay, then we'll attach the one single transducer. Okay, single transducer attached. So that will check the acceleration. Okay, that will check the acceleration of the baby. Okay, that will check the acceleration of the baby. What do you mean by acceleration? So nothing but whenever there is a fetal movement. Okay, whenever there is a fetal movement, we know that, okay, if the fetal moves, okay, fetal movement is there, so there will be increase. Okay, increase in the heart rate. Okay, increase in the heart rate of the fetal by more than, okay, 5 to 25 beats per minute variability will be there. Okay, means every fetal movement, okay, every quickening of the movement, okay, there will be increase in the heart rate by 5 to 25 beats per minute. Okay, so normally the fetal heart rate will be 120 to 160 beats per minute. Okay, 160 beats per minute. Okay, but during the fetal movement, okay, there will be increase in the heart rate of the fetus will be there. Okay, that's what your normal NST. Okay, we can say normal NST. Okay, normal NST or reactive NST. We can say that one as the reactive or the normal NST. So what will happen here? So I'll write down here exactly acceleration. Okay, acceleration is nothing but a increase in the fetal heart rate for every fetal movement. Okay, so here what is considered to be normal? So normal NST. Okay, normal NST or reactive NST. Okay, this one is itself your like your NORCET question. Okay, they ask it regarding the what do you mean by reactive NST. Okay, reactive NST. So reactive NST is nothing but okay, there will be a at least, okay, for every, okay, that all 15, okay, there will be a, for every fetal movement, okay, there will be increase in 15 heart rate. Okay, 15 beats per minute heart rate will be increased for at least, okay, for a duration of 15 seconds. Okay, and you can remember the rule of 15. Okay, 15 thumb rule in per second. Okay, for every heart rate will be there will be increase in the from baseline. Okay, if just think, okay, 120 is a normal baseline heart rate of the baby. So during fetal movement, okay, it increased to the 135 beats. Okay, for a duration of 15 seconds. Okay, for a duration of 15 seconds, there will be increase in the heart rate by the 15 beats per minute. Okay, that's what your normal NST. Okay, so that we'll do NST for 20 minutes we'll do a NST. Okay, for every 20 minutes we'll do a NST. If it is, okay, if it is reactive, okay, if it is reactive means normal. Okay, if it is normal, we will say, okay, for every duration, okay, at least two variability. You can say at least two acceleration. Okay, we want at least two acceleration for 20 minutes. Okay, two acceleration for 20 minutes of NST is considered to be a normal NST or a reactive NST. So that time we can send back the mother to home. Okay, if it is non-reactive, we'll repeat the NST. Okay, it's non-reactive means abnormal. We can say it's abnormal or non-reactive. We'll repeat the NST. Okay, we'll repeat the NST after 20 minutes of gap. Okay, again the NST is non-reactive. Then we will go for the conformity test. That is your biophysiological scoring. Okay, that's your biophysiological scoring. Okay. So normally what will happen? Okay, you can see normally like abnormality. What are the abnormalities of your NSTs? Okay, I'm telling you regarding the abnormalities of the NST. Okay, so ordinal abnormalities will be there. So now first we'll see before abnormality, we'll see normally. Okay, normally what will happen? Normally what will happen? Okay, so there will be a I can see this one is your fetal heart rate. Okay, fetal heart rate. Okay, suddenly it will rise. Okay, and it will come down. Suddenly it will rise down. Okay, it will come down. Okay, when it will rise on, I'm telling you when it will rise on, when there is a fetal movement. Okay, now there is a fetal movement is there. Okay, fetal movement. So there is the increased heart rate. Okay, so again one more fetal movement. Okay, there will be increased heart rate. Okay, fetal movement and heart rate. Okay, this one is the NST graph, and this one is the fetal moment. Okay, this one is the fetal moment. We call this one as the first one. We call that one as beat to beat variability. Okay, beat to beat variability. Okay, this one is considered to be normal. Okay, this one is considered to be a beat to beat variability, considered to be a normal. Okay, next one we'll see absent variability. We can see absent variability. Okay, absent variability means there is no beat to beat variability here. Okay, complete absent will be there here. Okay, you can see the like NST, it will be flat line. Okay, it will be starting to the baseline. Okay, this one is our NST graph. Okay, so even though there is a fetal movement, okay, even though there is a fetal movement, okay, so there is no changes in the heart rate. Okay, we call that one as like absent variability. This one you can see in a absent variability seen in a in case of fetal hypoxia. You can see in a fetal hypoxia and fetal acidosis. Okay, severe fetal acidosis is there. Okay, and there is a severe fetal acidosis is there. Okay, that time you can see the absent of the complete. Okay, disability of complete like absent of the variability will be there. Okay, you can see both of the like abnormal finding of the NST. Okay, and last one. Okay, last one, that is your last abnormality of the NST. Okay, that is what we call as sinusoidal. Okay, sinusoidal NST. Okay, sinusoidal NST. Okay, sinusoidal NST. Nothing but you can see here what will happen. The pattern. Okay, the pattern will become sinusoidal pattern. Okay, sinusoidal. Okay, like wavy pattern. Okay, so it is not the heart rate is not going more than a 5 minute. Also, okay, you can see fetal activity is here. Okay, fetal activity is here. Okay, so this one is the because sinusoidal NST. Okay, and this one is the fetal fetal activity. Okay, fetal activity or the fetal movement. Okay, so even though there is a fetal movement, there is no increase in the heart rate. Okay, we call this one as sinusoidal pattern. Okay, this one is seen in case of this one is seen in case of especially severe anemias. Okay, severe anemia you can see in case of vasa previa. You can see vasa previa, or else you can see in a RH isoimmunization. Okay, you can see in case of RS isoimmunization case. Okay, this all is seen in case of sinusoidal pattern is seen in case of severe anemia, vasa previa, and the case of RH isoimmunization. Okay, you can see. So here we're having the option number D is the right answer. Okay, sinusoidal pattern of the NST. Okay, so I told you this one is seen in case of vasa previa means fetal blood loss. Okay, and a severe anemia. Okay, and a severe anemia and RH isoimmunization. Okay, and RH isoimmunization. Okay, RH isoimmunization. Okay, in all case you can see the sinusoidal pattern of the your ENST. Okay, you can see fetal heart rate is okay, fetal movement is there. Okay, but there is no changes in the heart rate of the fetus. Okay, that's what you call as sinusoidal pattern of NST. Okay, this regarding the like next question. Okay, all of it clear? So option number D is the right answer. Okay, now next we'll go with the next question. Okay, so here we're having the like mother came to the psychiatric OPD with the complaints of severe depression. Okay, and after a detailed discussion, okay, found that okay her child was recently diagnosed with the acute lymphoblastic leukemia. So which type of loss currently mother is experiencing? Okay, option numbers are here. Option number A is primary loss. Option number B is the secondary loss. Option number C is the physiological loss. Option number D is the external loss. Okay, option number D is the external loss. Okay, just try to put your right answer in the comment box. I'm waiting for your right answer right now here. Just you can see, okay, primary loss. Okay, so here according to the like psychiatry, you can see primary loss is something. Primary loss is something. Okay, which is which is close one's death. Okay, close one's death or the like close one's illness. Okay, like illness also serious illness of the closed ones. Okay, loved ones also considered to be a primary loss. Okay, here what will happen? There will be a death of somebody. Okay, death of loved ones. Okay, death of loved ones or any serious illness of loved ones also considered to be a serious illness. Okay, serious illness of the loved ones considered to be a like loved ones considered to be a primary loss. Okay, here what will happen? The like a direct effect will be there. Okay, there will be a direct effect from the event will be there. Okay, direct effect from the uneventfulness, okay, uneventfulness, okay, this, direct effect from the uneventfulness, okay, any death, okay, any serious illness of the like loved ones, that will have a direct effect on the individual, okay. So here what will happen, there will be a, it is a primary effect, okay, it's a initial effect, okay, it is an initial effect, means you can able to perceive, you can able to feel the closed ones death, or else a closed one's illness is a considered to be a loss for the very big loss for the individual, okay. That's why it is a, so serious illness of the child is considered to be a primary loss, okay, it's a primary loss. So option number A is the right one, okay. I can see NORCET, okay, like last, or like RRB who has given, so they ask it regarding the like stages, okay, Kubler loss stages of the like grieving, okay. So you can see, okay, so just it was came in exam, we can see Kubler-Ross, okay, Kubler-Ross stages of the grieving, okay, stages of grieving, okay, grieving nothing but the like like events, okay, after loved one's death, okay. So what are the like stages for the response for the loss, okay, response for the loss of somebody's, okay, we call that one as the grieving, okay. Grieving, okay, we are having the like a mnemonic, okay, that's what we call as dabda, okay. Dabda is the mnemonic for remembering the Kubler-Ross stages of grieving, okay. D for first, okay, first anything, okay, happens, okay. Loved ones has been death, okay. So they had expired. What will happen? We'll deny completely. We'll deny. Okay, so no, he's not death. Okay, he's already present. Okay, don't tell like that. So we'll deny. Okay, we'll try to avoid the situation. Okay, we'll not accept the situation. Okay, so first we'll try to deny. Okay, after that, what will happen? We'll argue. Okay, after that, we'll do argument. Okay, we'll do argument, means we'll say it's not happened. Okay, it's not the right one. Okay, after that, that's the first denial, okay. First we'll try to avoid, first we'll try to not reject that one, okay. First we'll try to reject. So after denial, okay, after rejecting that one, okay, after rejecting, we will completely say, will argue, always will show anger, okay, will show angry, will show along with the anger, like arguness, will show anger, okay, will show our all like angerness towards the situation, okay. So that is what the second stage, okay. Then we'll go for the third one, okay. So after that, okay, we'll start to bargain, okay. We'll start to bargain, okay. Just I'll give an example, okay. First, like I will tell you same example only. So somebody like loved ones of you has diagnosed with the cancer, okay. You knows that, okay, the person will be going, if the cancer comes in, okay, they'll not treatment, proper treatment for the cancer, so the person will be getting expired, okay. So first thing what we'll do, no, he's not got the cancer, okay. First we'll try to deny he's not diagnosed with the cancer, okay. It's maybe something else like that, we'll deny, okay. After that, what will happen, we'll show our anger, okay. After confirming that, okay, he's having the cancer only, so we'll try to show the anger, okay. So why the God has given to me, so we'll try to show so much anger on the God, okay. God is very cruel, so he's given us so much of like a cancer for my loved ones, okay. So I'll try to show the angerness, okay. After that, I will bargain, okay. After that, I'll bargain to God, okay. Just give me like a, just extend my life for 2 years, okay. Just extend my life to the 3 years, like that I will bargain, okay. After bargaining, last one is the like fourth stage will be a depression, okay. After bargaining, I'll be going for the depression, okay. I'll be going for the depression, okay. After that, lastly, acceptance, okay. Last, okay, I'll get to know, I'll realize, okay, I'll slowly realize, and we'll get to know, I'll be going soon. So that time I'll go for the acceptance, okay. Last stage is the acceptance stage, okay. This is the 5 stages of Kubler-Ross of grieving, okay. And last one, okay, last question of the session, okay, that's the 10th question. Here we're having the like 24-year female comes to the like obstetric casualty with the complaints of reduced fetal movement, okay. On X-ray found that, okay, there is a gas in the greater vessels of the fetus, okay. Based on the X-ray findings, okay, which sign is the fetal death denotes, okay. Options are here. Option A is the Spalding sign, option B is the Ball sign, option C is the Robert sign, option D is the turtle sign, okay. You can see, like again, you may heard that word called as DFMC, okay. What do you mean by DFMC? DFMC nothing but the daily fetal movement count, okay. We call that one as a daily fetal movement count, okay. DFMC, okay. Daily fetal movement count, okay. We call that one as daily fetal movement count, okay. So for every day, okay, for every day, like pregnant woman, okay, for every day she has to do a DFMC, okay, rule of count 10. So after like 2 years, okay, 2 hours of rest, okay, even after the food, okay, because it is like after food is recommended because glucose will be there, so there'll be a more fetal movement, okay. So please there'll be a 10 movement, okay. At least there will be a 10 fetal movement should be there, okay. That's considered to be a normal, okay. If you're walking, okay, if you're not taking a rest means, okay, for 12 hours, okay, there should be a 10 fetal movement should be there, okay. That's considered to be a normal. Okay, so females start to have a quickening. Okay, means fetal movement nothing but the quickening after the 16 or 18 weeks of gestation. Females start to have a quickening means feeling of the fetal movement. Okay. If it is reduced, okay, if it is reduced then the less than 10, okay, less than 2 is considered to be a reduced fetal activity, okay. So it denotes there is a something abnormality, fetus in distress or a fetus having a intrauterine death, okay, that will be there, okay. So on X-ray as taken, okay, you can see on Spalding sign, okay, Spalding sign nothing but there will be a like a overlap of the skull, okay, overlap of the skull is called as a Spalding, okay, overlap of the skull bone is called as a Spalding sign, okay. So here they given a greater vessels, okay, there will be gas in a greater vessels, okay. So that is what your like Robert sign is, okay. So option number C is the right answer, okay. In the Robert sign, so there will be a gases present in the greater vessels, okay. And what do you mean by ball sign? Ball is nothing but a spine, okay. There is a spine hyperflexion or a spine hyperflexion or hyperextension is called as ball sign, okay. And turtle sign, you know that, okay. In a shoulder dystocia, okay, what will happen in a shoulder dystocia? The baby's head, okay, the baby's head will come and go, okay, baby's fetal head will come out and go, come out and go inside, or come out and go inside, okay, that's what we call as turtle sign, okay, turtle sign, okay, this all are the signs, okay. So option number C is Robert sign, it's not, okay, there is a gas in the creative vessels, okay, option number C is the right answer, okay. Thank you all for watching it, okay, keep on learning, keep on studying, okay, stay connected with the class, okay. If you want means, okay, I can have one more, okay, so one more last MCQ we can see. So here we're having the from surgery aspect, okay, we are having the 48-year-old male comes to the with the chronic history of alcoholic, okay, has been undergone for the diagnostic laparoscopy, okay. So we know that, okay, alcoholic, what will happen, there will be a peripheral bleeding will be there, okay, there will be a gastritis will be there, okay. So person will have a hematemesis, okay. For that one they done a diagnostic endoscopy, okay. And the endoscopy impressions are shows pre-sinusoidal portal hypertension, okay. They're having the pre-sinusoidal portal hypertension, okay. That is the diagnosis, okay. That is the diagnosis by the as made by the diagnostic endoscopy, okay. That is what your pre-sinusoidal, okay, pre-sinusoidal hypertension, okay, portal hypertension is there, okay, and like what are the cutoff, okay, what are the cutoff value of HPVG, okay, what do you mean by HPVG? Sorry, HVPG, HVPG nothing but a hepato, hepatovenous hepatovenous pressure gradient, okay, hepatovenous pressure gradient is the full form of the HPVG. So they are asking you regarding the cutoff value for the HPVG gradient, okay. Option number A is 1 to 5 mmHg, option number B is 6 to 10 mm of Hg, option number C is more than a 12 mm of Hg, option D is the more than 20 mm of Hg, okay. Just try to put a like, what is the cutoff value to diagnose the pre-sinusoidal portal hypertension, okay. So just choose the right answer in the comment box. I'm waiting for your answer right now. Okay, to especially to, okay, to diagnose, okay, to diagnose the portal hypertension, okay, to diagnose the portal hypertension, so they will do a endoscopy, okay. Based on endoscopy they will get to know, what is the HPVG, okay, what is the hepatic venous pressure gradient, okay. So I'll tell you the cutoff values, okay. First one to say 1 to 5, okay, 1 to 5 is considered as 1 to 5 mm of Hg considered to be a pressure is considered to be a normal, okay. It is a normal finding, it is a normal, nothing to do for this for this 5 to 6 mm Hg. Next to see 6 to 10 mm Hg, okay, 6 to 10 mm Hg, it denotes, okay, denotes the pre-sinusoidal, okay, we know that, okay, liver is having the main like a main functional unit, that is a whatever like fenestrated capillaries, we call that one as sinusoids, okay. Sinusoids are very plays a very important role in detoxification of toxin, okay, or bacterial infection, okay, everything will be run through the sinusoids only, okay. Okay, so, like HPVG of 6 to 10 mmHg denotes, okay, there is a pre-sinusoidal, okay, pre-sinusoidal portal hypertension, okay, denotes a pre-sinusoidal portal hypertension, okay. And and pressure of more than or equal to the 12 mm of Hg, okay, denotes there is a risk to bleed, okay, there is a risk of variceal bleed, okay, denotes there is a portal hypertension along with the risk of variceal bleeding, okay, variceal bleeding, okay, and more than, okay, fourth one, more than a 16, okay, more than 16 to 20 mm Hg, it denotes, okay, there is a higher risk of mortality, okay, there is a higher risk of mortality mortality associated with the associated with the associated with the associated with the variceal bleeding, okay, variceal bleeding, okay, that's what your HPVG gradients are, okay. It's all regarding the portal venous hypertension. Okay, all of clear regarding the classes. Okay, so in like one more today, tomorrow I'll be coming with the again one more 10 different questions. Okay, from the different all subject. Okay, just waiting for the let's wait for the session. Okay, we'll be giving you a high content with the high quality. Okay, so this all are authentic information. So after referring only, so with the trip ladder, okay, with the marrow, with all DMS, okay, all nursing next live. Okay, so all are like, with the all reference. Okay, so we'll be like giving a high reference, okay, high qualities we are giving you. Okay, so thank you all for watching. Keep on learning, keep on studying.